Hi and welcome back to another video of Medic Notes. This video is on viral myocarditis. Myocarditis is an inflammatory heart muscle process with focal and diffuse involvement. Clinically, myocarditis can present as an acute, subacute, or chronic disease process. The presentation can be highly variable in symptomatic patients, from generalized fatigue, malaise, chest pain, congestive heart failure, cardiogenic shock, arrhythmias, and cardiac arrest. Myocarditis can occur in an otherwise healthy person and quickly result in progressive heart failure. Myocarditis may be acute, lasting less than 2 weeks, or chronic, lasting more than 2 weeks. Etiology can be divided into infectious and non-infectious. Infectious are mainly viral, such as parvovirus, HHV6, EBV, enterovirus, CMV, adenovirus. Other causes include bacteria, COVID, influenza. Non-infectious causes are autoimmune disorders, such as SLE and others. For its pathophysiology, acute stage 1 to 7 days, defined by direct viral cytotoxicity and focal or diffuse necrosis of the myocardium, with subsequent exposure to host proteins and activation of the innate immune response. Adenovirus and enterovirus cause direct cell toxicity, whereas parvovirus infests endothelium and releases pro-inflammatory cytokines. Influenza causes T-cell regulated inflammatory response. Next is the subacute stage, which is 1 to 4 weeks. An increase in autoimmune-mediated injury with activated T cells and B cells and subsequent antibody production, creating cardiac autoantibodies and inflammatory proteins. There are higher concentrations of anti-B myosin antibodies in patients with myocarditis with dilated cardiomyopathy than in control groups. And lastly, the recovery or chronic stage depends on the presence or elimination of the viral genome in the myocyte. Chronic T-cell mediated inflammation results in remodeling and diffuse myocardial fibrosis, affecting cardiac dysfunction and leading to dilated cardiomyopathy and its sequelae, such as CHF, ventricular dysrhythmias, and abnormal ECG findings. Th17 cells are believed to play a significant role in this chronic phase of myocarditis. The exact pathophysiology mechanism of COVID-19 infection and myocarditis needs to be better established. The direct role of angiotensin-converting enzyme 2 receptors and hyperimmune response are plausible theories causing myocarditis with COVID-19. COVID-19 mRNA vaccines are also associated with acute myocarditis, and the etiology is unknown. The role of mRNA immune reactivity, antibodies to SARS-CoV-2 spike proteins, and hormonal differences might be the most likely explanation. For clinical features, viral myocarditis is typically seen in young males with varied clinical presentations. Patients typically present with a 7 to 14-day history of mild flu-like illness, including fever, malaise, myalgia, vomiting, and diarrhea. Rarely do they have debilitating symptoms like dyspnea at rest, palpitations, and sudden cardiac death. Adults typically present with chest pain, dyspnea, fatigue, syncope, palpitations, fever, tachycardia, and tachypnea. Hypotension may be seen. The presence of chest pain or CHF symptoms often indicates a poor prognosis. The 2013 European Society of Cardiology classified acute myocarditis into 3 profiles. Acute coronary syndrome-like presentation, including chest pain, ST or T wave changes on ECG, troponin elevation, and wall motion abnormalities. New onset progressive heart failure, which includes impaired left and right ventricular dysfunction, nonspecific ECG changes, heart blocks, or arrhythmias. Severe life-threatening fulminant conditions, such as cardiogenic shock requiring vasopressors, mechanical life support, and ventricular arrhythmias requiring defibrillation. The physical examination findings are similar to CHF and may include an S3 gallop, rales, tachycardia, and dependent edema. Special cases of myocarditis include the following. Sarcoid myocarditis presents with heart block and associated lymphadenopathy. Giant cell myocarditis presents with ventricular tachycardia and heart failure. Acute rheumatic fever presents with chorea, erythema marginatum, polyarthritis, and subcutaneous nodules. For investigations, nonspecific ECG findings, such as sinus tachycardia, wide QRS patterns, low voltage, prolonged QT, variable atrioventricular blocks, and acute myocardial infarction patterns. Elevated troponin levels may suggest more damage to the heart muscle, indicating My1 necrosis. Tests to determine complete blood count, ESR, and CRP levels are recommended. Elevated white blood cell and CRP levels or faster ESR might occur but are inconclusive for diagnosing the condition. Viral antibody titers should also be ordered, including Coxsackie group B, HIV, CMV, Epstein-Barr virus, hepatitis, and influenza viruses. Transthoracic echocardiogram is usually the first imaging modality of choice in suspected myocarditis. The most common finding includes preserved left ventricular ejection fraction without regional wall motion abnormalities. It may show nonspecific findings such as reduced left ventricular function, global hypokinesis, and regional wall motion abnormalities. Cardiac MRI is the best non-invasive imaging modality for both diagnosis and follow-up. Another investigation is endomyocardial biopsy. According to the revised Louise criteria 2018, in the setting of clinically suspected acute myocarditis, cardiac MRI findings are consistent with myocardial inflammation if both T1 and T2 based criteria are present, as follows. Supportive criteria include the presence of pericardial effusion in cine cardiac MRI images or high signal intensity of the pericardium in LGE images, T1 mapping or T2 mapping. The presence of systolic left ventricular wall motion abnormality in cine cardiac MRI images. For treatment, for the most part, treatment of myocarditis is supportive and aimed at preserving left ventricular function. Treatments range from activity limitation to rhythm control and CHF management. Patients with heart failure often require diuretics and inotropic support. Long-term treatment with ACE inhibitors is recommended. Avoid cardiotoxic drugs and NSAIDs, as they can hinder the healing of the myocardium and exacerbate the inflammatory process. Some patients may require anticoagulation. Physical activity should be limited during the acute phase of the disease. Patients with mild myocarditis usually have a good prognosis. Poor prognostic factors include low ejection fraction, left bundle branch block, and syncope. The patients may also develop varying degrees of heart block and require permanent pacing. Cardiogenic shock is the most common cause of death, with the highest mortality rates in postpartum cardiomyopathy. That's all for this video. Thank you.